Kichu Nair. Hello, sir. Good afternoon.
Kichu, I can't see him in this.
I am seeing him.
Muted or no? Okay.
He's muted.
Kichu sir, good afternoon.
Kichu sir is keeping quiet, strangely enough.
He is mute.
Why?
I think, please unmute, sir.
Good afternoon, Vijayan sir.
Hello. ഇതിൽ പോയിന്റർ വേണമെങ്കിലോ
Okay, I'm unmuted now.
Yeah.
Unmuted.
So happy to see you.
Good to see you all too.
We say good afternoon. For you, it must be good morning.
Good evening.
No, it's 6:30 in the evening.
Good evening.
I finished my day's work.
Okay, wonderful. Okay.
So how many people are you expecting to join?
Subhadra, you can tell. Subhadra is coordinating.
So, the slot was almost all over.
Okay.
More than 100.
Yeah.
Okay, excellent.
Only
And it is live streamed in YouTube also.
Yeah.
Oh, excellent. Okay.
Yeah. So,
very good.
The people are entering. We can start by 2:00.
Can start by 6:30.
Yes.
Yes.
okay.
Krishnan, are you in Calicut or?
Very much in BMH, baby.
Okay.
How are you?
I'm good. We are watching the Calicut, in the news now. Last few days.
Very much. Sad, isn't it?
Very sad. When is Onam? Onam's supposed to be in September.
29th, 30th. 30th and
of
1st.
August.
30th and 31st.
Yeah,
August.
end of this month.
Okay.
Yeah.
Onam is.
How are you going to celebrate it?
How is anybody going to celebrate? I don't know. Yeah.
With mask, with social distancing.
That's right. Yeah. Then Onam Sadhya will be. Yeah.
Sadhya will be online Sadhya.
Online Sadhya will be good. Yeah.
Mohan, have you lost weight?
I'm trying to lose more.
Very political answer. Right?
That's right. Yeah. That's right.
എന്റെ തല വെട്ടിപ്പോകും
Points are start ചെയ്താലോ?
Maybe we can wait 2-3 minutes more. People are joining. Yeah, people are
waiting.
Yeah, because there will be some technical hitches, so that let them take time.
Yeah, due to the rains and all. Everywhere it is a problem now.
What's the temperature in Cochin now? Is it warm?
Because of
rainy?
rain. Yeah, it's
25.
heavy rain. Heavy rain.
It's 25 around here.
Okay, it's around 7-8 degrees here. I have the
Okay.
heating on. Yeah,
Oh, you're with the heater. Okay.
heat. I have the heating on. It's a 7 and goes to around 2 degrees at night time.
Okay.
Oh.
Yeah, so it's cold.
Okay. Now
There's a heavy rains too. So
heavy
in
rain.
way, yeah.
And floods. We are worried about the floods.
Yeah. 2020 is not a good year for any of us.
Yeah. 2020. And here we may would like to forget the year.
Yeah, exactly.
I'm very much here. I'm sitting so that I can watch the screen. Okay, whenever I must come on, I will.
I think
We can start.
now we can start. Yeah, we can start. We have waited 5 minutes for the people to have technical this thing, and now we can start. Yeah. Subhadra, you can start.
Thank you, sir. നമസ്കാരം. കേരള ആരോഗ്യശാസ്ത്ര സർവകലാശാലയിലെ സെൻറ്റർ ഫോർ ജെറന്റോളജിക്കൽ സ്റ്റഡീസിൻ്റെ കൺഫ്യൂഷൻ ഇൻ എൽഡർലി എന്ന വെബിനാർ ആരംഭിക്കുകയാണ്. ഈ വെബിനാർ ഉദ്ഘാടനം ചെയ്യുന്നതിനായി ബഹുമാനപ്പെട്ട വൈസ് ചാൻസലർ ഡോക്ടർ മോഹൻ സാർ എത്തിച്ചേർന്നിട്ടുണ്ട്. അദ്ദേഹത്തിൻ്റെ നിർദ്ദേശപ്രകാരമാണ് ഈ വെബിനാർ സാധ്യമായത് തന്നെ. അദ്ദേഹത്തെ ഈ പരിപാടിയിലേക്ക് സസന്തോഷം സ്വാഗതം ചെയ്യുകയാണ്. ആശംസ അർപ്പിക്കുന്നതിന് എത്തിയിരിക്കുന്ന PVC ഇൻചാർജ് ആൻഡ് കൺട്രോളർ പ്രൊഫസർ ഡോക്ടർ വിജയൻ സാറിനെയും ഈ പരിപാടിയിലേക്ക് സ്വാഗതം ചെയ്യുന്നു. കൂടാതെ രജിസ്ട്രാർ, ഡീൻസ് ആൻഡ് ബാക്കിയുള്ള യൂണിവേഴ്സിറ്റി ഒഫീഷ്യൽസിനെയും സ്വാഗതം ചെയ്യുന്നു. നമ്മുടെ സെഷൻ കൈകാര്യം ചെയ്യാൻ സമ്മതിച്ച ഡോക്ടർ കൃഷ്ണൻ സാറിനെയും ഈ പരിപാടിയിലേക്ക് ക്ഷണിക്കുന്നു. അതുപോലെ തന്നെ ഈ പരിപാടിയിൽ പങ്കുചേരാൻ എത്തിയിരിക്കുന്ന നിങ്ങൾ ഓരോരുത്തരെയും, പ്രത്യേകിച്ച് ഡോക്ടർ നന്ദിനി കുമാർ മാഡം വരാമെന്ന് പറഞ്ഞിട്ടുണ്ട്, ഷാജി സാറ്, കിച്ചു സാറ്, എല്ലാവരെയും ഞാൻ ഈ വേദിയിലേക്ക് സ്വാഗതം ചെയ്യുകയാണ്. ഈ പരിപാടി ഉദ്ഘാടനം ചെയ്യുന്നതിനും ഉദ്ഘാടക പ്രസംഗം ചെയ്യുന്നതിനുമായി ബഹുമാനപ്പെട്ട VC ഡോക്ടർ മോഹൻ കുന്നുമ്മൽ സാറിനെ ക്ഷണിക്കുകയാണ്. Please.
Thank you, Dr. Subhadra. Provice Chancellor Dr. C.P. Vijayan, the Speaker and Guest of Honor Dr. Krishnan, and the eminent gerontologist, internationally renowned gerontologist Dr. Kichu Nair, eminent psychiatrist and gerontologist Dr. Shaji, and my dear faculty members from the Kerala University of Health Sciences and officials of the Kerala University of Health Sciences. We have been conducting these webinars for the last few days because of the new norm. We conducted an excellent 2-day conference on geriatric issues just before this COVID pandemic started. And that was eminently done by Professor Krishnan at BMH. And the university was so happy to collaborate with BMH. And it was accepted as one of the best gerontology conferences conducted in the recent years. and the narrated by this conference is going to be published soon. And I should say that immediately after taking over as the Vice Chancellor, I had the fortune to discuss with Dr. Krishnan, and we had discussed various ideas on focusing on gerontology. And Professor Shaji was also there. And we decided to have various programs, courses, training programs, because in Kerala, Kerala, of course, is part of a developing country. We have various good fortunes and bad fortunes of a developed country. And one among them is to have large number of elderly people. And therefore, various national policies and national programs may not touch Kerala because rest of India does not have that many number of elderly people. So we should have our own programs to tackle the problems of elderly, which rest of India will copy down later when they become like Kerala, where the life expectancy will increase like Kerala. So we have to be pioneers and we have to create new knowledge and we have to Kerala specific programs. And that is why we conducted one such program along with BMH in Calicut. Now we will have similar programs in the university, but then this COVID has changed everything. We cannot meet each other. We cannot touch anybody, no more shake hands. And the new norm is sit as far away from the other person, thinking that anybody around you is a carrier of a disease. So that's a very dangerous situation. So anybody else is a carrier of a disease. So you sit as far away from everybody. And then, and you should not talk to him because when you talk, the viruses will jump from your mouth. You will not talk. You will not, you are not even supposed to breathe. So you have a mask. That's a very dangerous situation. Then how do you communicate? But then problems will create solution. And the solution is the webinars, distant learning, distant teaching, these kind of things. All this technology was available there. It was there for so many years, but it was not needed. But we started using it. Now we are slowly becoming masters of that. And this will become a robust platform. In fact, the university is creating one robust platform university for universities on that is called Moodle, which is based on an open source. So we are gaining a lot of experience. So we are using this wonderful platform and we are coming back and going to conduct everything we wanted to conduct, and probably we'll conduct in a much, much better way. And now regarding the topic, confusion in elderly, Professor Krishnan is the best person who can talk about this topic, the biological basis, psychological basis, and all aspects, and how to handle such problems. He has been handling such problems in BMH, in Government Medical College, Calicut, one of the best teachers Kerala ever had in medicine. He's a great teacher, and we were working together in the university also, and I had experiences the way of he was working in Calicut Medical College, where I could work for a short period. So all these on all these grounds, he's the best person we can have, and I'm so happy that Dr. Krishnan is here. He can make some comments on the topic with his very wide experience, international experience, and Dr. Shaji is also here, and all other, and Dr. Rajmohan is here. He's a world-renowned epidemiologist. So all our faculty are here. So with these few words, I declare this program inaugurated, and I request Dr. Krishnan. Of course, after me, Dr. Vijayan will be making his remarks, and after that, I request Dr. Krishnan to make his speech. Thank you so much.
താങ്ക് യു സർ. സാറിൻ്റെ വിലയേറിയ ഉപദേശങ്ങൾക്ക് നന്ദി. സെൻറ്റർ അതിന് തക്കവണ്ണം പ്രവർത്തിക്കാൻ ശ്രമിക്കുമെന്ന് അറിയിക്കട്ടെ. ആശംസ അർപ്പിക്കുന്നതിനായി PVC ഇൻചാർജ് ആൻഡ് കൺട്രോളറുമായ പ്രൊഫസർ ഡോക്ടർ വിജയൻ സാറിനെ ക്ഷണിക്കുകയാണ്. സർ പ്ലീസ്.
Honorable Vice Chancellor of Kerala University of Health Sciences, Professor Dr. Mohanan Kundummal, other officers of the university, Dr. Subhadra, your head of the organizing team, Dr. Krishnan, former professor of Calicut Medical College, Dr. Kichu Nair is a world-renowned expert in gerontology, and respected teachers. As mentioned by our Honorable VC, Kerala is having all the hallmarks of a developed nation, and the proportion of elderly people above 65 is almost 1 in 11 now. And we are expecting it to change to 1 in 4 by 2050. That is the statistics as far as a developed nation is concerned. And the concerns of the old people, old generation is facing us very much. The number of elder people above 65 years has already crossed the under 5 population. So most of the other states of the other states of India may be focusing on under 5s, may be focusing on other marginalized population, but may not be that much interested in the elderly population, as mentioned by Honorable VC. But tomorrow they will have to turn towards this problem, and let us be the torch bearer of the problem of elderly and measures to tackle them effectively. And I know that I came to know that Dr. Krishnan, unfortunately, I don't have any personal relationship with him. But I am sure that I heard about the conference held at Baby Memorial Hospital in 2020, early period. And it was a grand success, and I am sure that this program also is going to be a successful one. Best wishes for it. Let us hear it. Thank you.
താങ്ക് യു വിജയൻ സാർ. ഇനി നമ്മൾ ഇത്രയും നേരം കാത്തിരുന്ന സ്പീക്കറിനെ പരിചയപ്പെടുത്തട്ടെ. സ്പീക്കറിനെ പരിചയപ്പെടുത്തണമെങ്കിൽ എനിക്ക് 2 മണിക്കൂർ പോരെന്നുള്ളതാണ് എനിക്ക് തോന്നുന്നത്. സാർ പറഞ്ഞിട്ടുണ്ട് വളരെ കുറച്ച് കാര്യങ്ങളെ പറയാവൂ എന്നോട് താക്കീത് ചെയ്തിട്ടുണ്ട്. ഈ ഒരു പ്രോഗ്രാമിന്റെ കാര്യം പറഞ്ഞപ്പോൾ തന്നെ സാർ വളരെയധികം ഉത്സാഹത്തോടെ കുറേയധികം ഉപദേശങ്ങൾ തന്നിരുന്നു ഈ പ്രോഗ്രാമിനെ കുറിച്ച്. നമ്മുടെ ബഹുമാനപ്പെട്ട VC സാർ പറഞ്ഞതുപോലെ വളരെ നല്ലൊരു പ്രോഗ്രാം BMHൽ സാർ ചെയ്ത് കാണിക്കുകയും ചെയ്തിരുന്നു. അത് കഴിഞ്ഞിട്ട് സെൻട്രൽ സോണിലും സൗത്ത് സോണിലുമായിട്ട് ചെയ്യണമെന്ന് സാർ ആവശ്യപ്പെട്ടിരുന്നു. പക്ഷെ അതിനിടയ്ക്ക് കോവിഡിന്റെ ഒരു പ്രശ്നം കാരണം അത് മാറിപ്പോവുകയാണ് ചെയ്തത്. ഈ ടോപ്പിക് കൈകാര്യം ചെയ്യാൻ ഏറ്റവും യോഗ്യനായ വ്യക്തിയാണ് അദ്ദേഹം ഗവൺമെന്റ് മെഡിക്കൽ കോളേജിൽ നിന്നും പ്രൊഫസർ HOD മെഡിസിൻ ആയിട്ടും സൂപ്രണ്ട് മെഡിക്കൽ കോളേജിലെ ഹോസ്പിറ്റലിലെ സൂപ്രണ്ടായിട്ടും വിരമിച്ചതിന് ശേഷം പെരിന്തൽമണ്ണ MES കോളേജിലും ഇപ്പോൾ ബേബി മെമ്മോറിയൽ ഹോസ്പിറ്റലിൽ സീനിയർ ഫിസിഷ്യനായും ജോലി നോക്കി പോരുന്നു. അദ്ദേഹം KUHSന്റെ ഫാക്കൽറ്റി ഓഫ് മെഡിസിൻ മെമ്പറും ബോർഡ് ഓഫ് സ്റ്റഡീസ് മെമ്പറുമാണ്. അതുപോലെ തന്നെ കാലിക്കറ്റ് യൂണിവേഴ്സിറ്റിയിലും അക്കാഡമിക് കൗൺസിൽ മെമ്പറും ഡീൻ ഫാക്കൽറ്റി ഓഫ് മെഡിസിനുമായിരുന്നു. അദ്ദേഹം ജിറിയാട്രിക്സിൽ 3 വർഷം സതാംപ്ടൺ UK-യിലും വർക്ക് ചെയ്തിട്ടുണ്ട്. ഇത്രയും വളരെ ചെറിയ രീതിയിൽ ഞാൻ പറഞ്ഞു ഒതുക്കാൻ ശ്രമിക്കുന്നതാണ്. അദ്ദേഹത്തിന് അനവധി നാഷണൽ ആൻഡ് ഇന്റർനാഷണൽ പിയർ റിവ്യൂഡ് ജേർണൽസിൽ പ്രസിദ്ധീകരണങ്ങളും ഉണ്ട്. അദ്ദേഹത്തിന് ഈ പരിപാടിയിലേക്ക് പ്രഭാഷകനായി വളരെ അഭിമാനത്തോടെയാണ് ഞാൻ ക്ഷണിക്കുന്നത്. സർ പ്ലീസ്.
Thank you, Dr. Subhadra, Dr. Mohan, and Dr. Vijayan. Great words of praise, but I'm not so sure that I deserve most of it. I thought Mohan and Subhadra were excellent organizers, but I didn't realize they were also prone to exaggeration, and therefore, thank you, but don't believe a word of what they say about me. The topic for today is confusion in the elderly, and I divided it into 3 sections: the salient points, the illustrative cases, and take-home messages. And what I'd like to do, as I told Subhadra, immediately after salient points, we'll take a break where you can ask questions. And I'm sure Mohan will provide us the vada and the biscuits and the coffee, at least online. And we'll then carry on with the illustrative cases and the take-home messages. It's a strange feeling to talk to an empty hall because we are so used to talking to big crowded auditoria. So it is a bit strange, this webinar, but I must proceed. I've divided it into several little topics, and we'll start off with the first, which is defining the problem and discussing its magnitude. Now, if you take any emergency department, especially in a large hospital, you have about 30% of the acutely ill people having an acute change in mental status. The mental status is a barometer of underlying health and assesses its the physiological, neurological, and psychiatric status of a person. And a change in mental status may be the only symptom of an underlying disease, which one is difficult to say. Unfortunately, it complicates hospital stay and increases mortality to 25 to 35%, similar to sepsis. It's a disorder of attention and arousal, manifest with sudden onset and characterized by fluctuations. The other names are acute toxic psychosis and acute confusional state. All these are reversible. So confusion, for all practical terms, is equal to delirium. So they are synonymous. Now, these are the parameters that we assess: attention, awareness. Attention is the ability to select a particular stimulus and direct and focus on it to the exclusion of others. Awareness is an orientation of environment. They develop an abnormality in these developing over a short period of time and fluctuating during the course of a day, where a cause is often possible to identify, characterize, delirium. The word confuse means to mix or pour. It's an old word. And in other words, it means to throw into disorder. The layman uses it in the meanings of perplex, mystify, puzzle, and so on. While delirium means to be in a frenzy. It's a wandering in the mind. Now imagine you are confined to an ICU with all these lines stuck into you. Excuse me. Oh, no. Okay. There's some disturbance. I'm sorry.
I think if somebody has muted, please mute. Yes.
That's probably likely.
Please mute. Everybody, please mute. Other than the speaker, please mute. Otherwise, what is happening in their house, everybody will hear. Please mute.
Imagine one of us being stuck in an ICU with all these tubes and gadgets around you. The day-night variations are completely lost. There are nurses running around. There are doctors rushing around, maybe resuscitating the person next to you. And it's only likely that you get totally confused. And if the prevalence of delirium at admission to a hospital was 18 to 35%, by the time he is in the medical ICU, it goes up to 80%. This is true in the postoperative ward as well, where 10 to 50% or 35% in nursing homes, and towards the end of life, 45 to 80% of those above 65 have delirium. Unfortunately, all these prolong hospital stay and increase the economic and health care burden. Now, there's a distinction that has to be drawn between delirium and dementia versus, of course, senescent memory loss. This is something we hear every day. I do this all the time. Where are my glasses? What have I done with my keys? And I have the glasses stuck on my nose all along. And this famous picture in My Fair Lady, where Rex Harrison asks Eliza Doolittle, where the devil are my slippers? So we label all these as senescent memory loss and do not wish to use the term dementia, because when you use the term dementia, it also implies that there is a cognitive decline. So senescent memory loss, there is no global decline of cognition versus dementia where there is cognitive decline. The first thing, therefore, what you assess in a change in mental status, which applies to patients who are coming into hospital, which has come on suddenly and are prone to fluctuation. In other words, delirium. Is it new or is it old? If it is new, it might be reversible, and then you call it delirium. Is it of long standing and progressive, then you consider dementia. Unfortunately, even in patients with dementia, a superadded illness can cause a fluctuation, a dramatic fluctuation in mental status. And we must tell the caregivers and others to alert a physician, because in dementia, if there is a sudden change, it means that medical help has to be sought and fairly urgently. Because dementia takes a slow downhill course and a sudden downturn indicates there's another superadded illness. Why does it happen? The pathogenesis. Nobody knows is a short answer. There have been changes described in the neuronal networks after diffusion changes were shown on very sophisticated investigations. There's a disruption of neurotransmitter systems, a decrease in cholinergic transmission, an increase in the dopamine transmission. Neuroinflammation results, increased microglial activities. All these together result in acute cognitive disruption and delirium. So delirium may be the only sign of an infection anywhere in the body, a cardiac problem, including an acute myocardial infarction. People greater than 70 or 80 may not have a chest pain, but they suddenly become confused. Metabolic causes of which we will go into in some more detail. Endocrine causes like hypothyroidism or adrenal deficiency. Plain and simple dehydration, a decline in nutrition, and probably most important, we come to the category of drugs, including alcohol. As we all get older, there are changes in cognition, reflexes, gait and balance, sensory system, and sleep. Especially with the loss of vision and hearing, a person may be totally be confused or totally unable to know where he is in a new environment. All these aging processes contribute to morbidity, result in falls and fractures, and on top of it, if there is an infection or a subdural hematoma, or maybe an MI and an arrhythmia, and last but not least, subclinical seizures, the patient is totally at sea. So in the assessment of delirium, certain things have to be considered. Is this person a vulnerable person? Is he cognitively impaired even in the past, or has he been serious morbidities, comorbidities? In which case, a single insult, which may be very benign, may tip the balance and set him off into delirium. In a more robust person, multiple noxious insults are needed, and these may be cumulative or multifactorial. There are many predisposing factors for delirium. a previous delirium, dementia increases the risk by 2 to 5-fold, comorbidities of different sorts, loss of hearing, vision, etc., alcohol, increasing age, and medications in 40%. And please remember that 30% of those with delirium have already pre-existing dementia. In an ICU, for example, precipitants include immobilization, various tubes, physical restraints, a strange place, deprivation of sleep, the very fact that he has pain, and psychological or social stress. Now, this is a common problem. A person is admitted to hospital with a fall and then a fracture. He is immobilized. He probably gets an infection on top of this and he goes into delirium. And then what does the junior resident do? He gives this gentleman a bed with cot sides so that he does not clamber over, and puts him on medicines. And all these together increase the delirium, and he clambers over the cot side and has another fracture. This vicious circle we must stop. So the first step in understanding the problem is to evaluate it by recognizing first that there is a problem. All behavioral problems or cognitive impairment in the old are wrongly attributed to the patient's age, his dementia, or other mental disorders. Unfortunately, it is sad but true that more than 70% of clinicians fail to recognize this as delirium. And in another study, this is what I've quoted there, the American Journal of the American Geriatric Society of 2002. And more than 40% referred to a clinic for psychiatry opinion, in fact, had delirium and not the depression for which they were referred. Having recognized that there is a problem, you can confirm it. Please remember that any change in level of consciousness in anyone is to be taken seriously. Never assume that illness, loss of sleep, or fatigue is responsible. Lethargy and somnolence are not normal. And a person with dementia will never deteriorate rapidly. It's a slow downhill course, as I already mentioned. When you talk to him, you know whether his speech is tangential or whether he has memory difficulties, and whether his content in conversation is appropriate or not. These should all be warning signs, and please take the patient's bystander or family seriously when they say that this person has not been right for the last few days or weeks or whatever. And as a physician, you can make out whether during history he is unable to focus or on any particular point, and whether his responses are appropriate. If his conversation seems rambling, then of course these are all clues. And the performance during his mental status examination is more reliable than the actual score. So steps in assessment of delirium would include: 1, determine what is his state of arousal? What about his attention? Is he aware? Did it all begin suddenly? Are there any fluctuations? And can you identify a cause? This is what will be the refrain of my talk. Arousal, is he conscious? And that amply is measured by the Glasgow Coma Scale. And it may be near normal in delirium. It won't be quite normal, but it could still be normal and the person could be in delirium. And this is the Glasgow Coma Scale. Teasdale and Bennett from Glasgow used it in head injury, but we use it in virtually all causes of loss of consciousness. The maximum score possible is 15, the minimum or least is 3. Is the attention span normal? And for that, you have the tests of attention. Digits, ask him to count 15 forwards, he can normally do. Backwards, 5 to 3. Serial 7s, 100 minus 7, 93 minus 7, and so on, how much he can carry on. But this needs a little bit of arithmetic, and I find it, because I'm bad with arithmetic, I find it difficult myself. Can you spell a word backward? A formal mental testing is done by the MMSC. We'll go into that in a minute. These are the tests of attention, which are more formal, but we don't use it by the bedside. And in terms of awareness, is he oriented in time, place, and person? Did it come on so suddenly over a few hours or days? Are there ups and downs in the course of a day? At night, a person in a new environment would be totally at sea. He would probably be agitated, or he might even be withdrawn. And is there a cause that is obvious? Derangements of cognition include details of assessment of memory, recall, and so on. What are the instruments available? This is the standardized mini mental state examination, which we have used for several years. And this is the Montreal Cognitive Assessment Scale, which is called MOCA. But when they reviewed a series of bedside instruments, they found that the CAM, or the Confusion Assessment Method, was the best, and the MMSE was the worst in terms of accuracy. This is a comparison between the various tests that we normally use. While CAM is good for delirium assessment, MMSE and MOCA are better for cognitive screening in Alzheimer's and so on. This is the CAM, or Confusion Assessment Method, where there are 4 parameters. Is it acute onset with fluctuations? You can see it here. That's the list I'm reading out, or here. Acute onset, fluctuations, inattention, disorganized thinking, altered loss of consciousness. If you have 1 and 2, definitely, plus either 3 or 4, then the person is in delirium. It takes only 5 minutes to do the test. There's a more abbreviated version, which is called the 3-minute interview, where there are 4 parameters. Is there an acute change in mental status? Is there inattention? Is there disorganized thinking? And is there alteration in consciousness? In the first, has this occurred in the last 1 day? Has he become confused? Does he know that he's in hospital? Is he seeing things? Can he recall 3 or 4 digits backward, the days of the week backward, or the months backward? Does he can he recall his current year, the day, and whether he's in hospital? There is usually no loss of consciousness, and I'm dealing with patient responses here. The interviewer, on the other hand, documents fluctuations. Is he distractible? Are his ideas unclear or illogical? Is the conversation rambling? Is he hyperactive or is he hypoactive? 1 and 2 plus either 3 or 4 means delirium. So it takes only 3 minutes for that. Against a background of delirium, you have to know whether the person has dementia of long standing, and for that, the friends, carers, and family would be the best. You get from them a reliable witness, if available, what his baseline functioning was, what disabilities he had to cognition, and the sequence. Were there fluctuations in mental function, or has there been a slow deterioration or a sudden worsening? So he could have dementia, on top of which he could have an infection and delirium. The causes to exclude, I've divided it into 4. Drugs taking pride of place, neurological causes, non-neurological causes, and psychiatric causes. The psychiatric causes we will mention in passing, because I'm not a psychiatrist and I'm not qualified to talk too much about it. But does he have a high energy level, and is he angry and cheerful or aggressive, and that is mania? Is the energy level low? Is he tearful and fatigued? In which case we are going into depression. There is a loss of what is reality. He has suspicions and hallucinations. Then you call it psychosis. So these are psychiatric problems that I mentioned last in that list. Medication review is very, very important. It is important to take a list of not just the medicines he has been prescribed, or whether he's been taking them or not taking them, over-the-counter medicines, drugs from other physicians. Like as a physician, there may be a neurologist prescription or a cardiologist prescription or a pulmonologist prescription, which we may not take into account. Has he swallowed tablets or medications belonging to other household members, either out of ignorance or due to other factors? And it's a useful practice to get a family member to clean up his drug cabinet, and bring all the drugs so that we can review them. This is one of the things that I would like to emphasize and probably spend a couple of minutes, because all these are drugs which we use every day, whether they are analgesics, NSAIDs and opioids are particularly commonly used, a variety of antibiotics, be it penicillin, cephalosporin, and worst of all are the fluoroquinolones. And the fluoroquinolones are notorious in that they get across the blood-brain barrier and cause patients to become extremely drowsy and lethargic. You stop the fluoroquinolone and they get better. This has happened time and time again. And why do we use fluoroquinolone? Because in the US, people use fluoroquinolones for chest infection. So since we are great followers of the West, we use fluoroquinolones. I think that's a practice we should abandon. For simple infections, we should use other drugs. And then you have various atropine derivatives, all of which can cause confusion and delirium. And maybe if the person continues to take it, keep the delirium going on and on. All the anticonvulsants that we know, antidepressants, including the tricyclics, which we think are safe, various antiarrhythmics, methyl dopa especially, digoxin and diuretics can all precipitate and propagate delirium. Everybody has written essays on corticosteroids and the changes that they produce. All the anti-Parkinson drugs, especially levodopa, all of them can precipitate delirium. And surprise, surprise, even gastrointestinal agents like H2 antagonists, loperamide, which we hardly use generally, antispasmodics and antiemetics, drugs like, say, metoclopramide and so on, are notorious in this. Herbal preparations, a great variety. Those in the treatment of diabetes. Benzodiazepines are particularly notorious, even your muscle relaxants. So there is a huge list. And this is the very big list of drugs that are inappropriate in the elderly. I do not wish to go into that. It's the same thing, but in a smaller frame. Dr. Subhadra had promised that there would be a break. And if anybody wants to ask questions, now is probably a time to do it, because we could answer a few questions before going to the next half of the discussion. Can you?
Thank you, sir.
Ah.
സംശയങ്ങൾ ആർക്കെങ്കിലും ഉണ്ടെങ്കിൽ ചോദിക്കാം.
കമന്റ്സ് ആയാലും കുഴപ്പമില്ല.
അതെ അതെ അതെ, എന്ന് വെച്ചാൽ ഇനിയിപ്പോ അതിന്റെ ബാക്കി
I can't see the screen. How? Stop sharing. Yeah, that's better.
Please, anybody wants to ask a question, unmute yourself and then ask a question.
Yeah.
Or if you don't want to speak, you can ask your question in the chat box also. You can write in the chat box, so that will be seen and answered. Or you can unmute and talk, please.
Mohan sir, it could be a comment.
Welcome, Dr. Suma. Dr. Suma, Professor of Medicine. She is busy in the COVID duty. She has come here. Thank you.
Krishnan sir, it is so nice to see you now.
It's right. It's nice to see you too.
Because when I was told about this meeting, I thought that in between I have to cut another meeting and joined it, but I was a bit late. So I don't know whether this was introduced earlier. Krishnan sir has conducted an international meeting on geriatrics and gerontology last February.
They said all that.
I was also invited for that, but I couldn't attend it because other work came in between. So I find that this is the best chance to listen to some part of that. So that is why I thought that I'll definitely be part of this. And I'm happy that I'm listening to this. I don't have any questions so far because I always, because Krishnan sir is the past president of APA Kerala chapter and is very active in APA Kerala chapter, and always his presentations used to be unique. So
Used to be. Past it.
I was talking about APA. That's all.
Continues to be.
And I learned now it is continues to be. Okay, sir. I'll listen to it, and at the end, if there are any questions, I'll ask. I just wanted to say that I'm here listening to you. Thank you.
Thank you, Suma. There's a question from Tiju Thomas to everyone. Most of the patients are having polypharmacy. Can these drugs cause dilemma? What can we do about these conditions? I think the best thing that we can do is to stop all drugs under the circumstance unless they are absolutely necessary. And one of the things that we find often as physicians, Suma will certainly endorse my statement. I'm glad you're here on my side as a physician. Kichu is also a physician, so that's okay. I don't know who the others are listening. But we have a patient, many a time we have a problem with drug fever. And what actually happens is that we start giving cephalosporins to a person with, say, typhoid. After 7 or 8 days, the person is completely well, but the fever recurs. And the only thing that we can do is to stop, or if all the other parameters are okay, if the patient is well, we stop every drug. And then in hospital, that is what we do. I had this unique experience of working in Velo when Dr. Benjamin Mani Pulimud would say no drugs, not even vitamins. And I think that was a very salutary experience as far as I was concerned, where we would give no medicines and watch the progress of the patient, get the temperature recorded properly, and lo and behold, many a time the fever would come down. But this is taking a risk, especially in older people. I agree that it's a bit of a problem, Tiju Thomas, that there may be situations where you may have to be careful, but it is important to realize that you are doing, as a physician, more harm to the patient than anybody else, and therefore you may have to take a step back and revise your drug list. I hope that answers the question. I hope the others agreed to this. What do you think, Suma, Kichu Nair, and others? Shaji?
I think the anticholinergic potential, there are many drugs which have anticholinergic side effects.
Exactly.
For example, derifilin, Lasix, digoxin. So there could be cumulative anticholinergic effects which would tip off a delirium in a person with minimal cognitive reserve, especially an older person. So
antihistaminics, surprisingly.
Antihistaminics and anticholinergics. Apart from that, drugs like derifilin, Lasix, even ranitidine could have slight anticholinergic property. So when the old person is on many a drug, then this cumulative anticholinergic potential should be considered in every case.
One of the most offensive drugs in my book are the quinolones, which are used with gay abandon. And especially since this is a second-line drug for tuberculosis in this country, we should use it with much and utmost care. Any other questions, or shall we go on?
Not only alcoholism, alcohol withdrawal is also another cause.
Very true. We are coming to that, Alex.
Okay.
Yes, that's true. Very true. Two things. Hypoglycemia secondary to alcohol, and the effects of alcohol itself. And of course, delirium tremens, isn't it? And that's true for benzodiazepines also. We'll come to that. There is a little case study which I'm sure you'll appreciate better.
Also,
sorry, there is a question from Ragul Sen. How will a hypoactive delirium be present? Basically, it's that energy levels are low, they are mute and withdrawn, as against a hyperactive delirium where they are aggressive and jumping around and pulling out all tubes and so on. Shaji is the better person to answer that. Would you like to say something?
I think big problem with hyperactive delirium is that we tend to miss it because you don't notice when you take rounds that somebody is, or even when you notice, it will not cause distress in you that someone is slightly withdrawn, unlike a person who is very disruptive. So it's very well known that we tend to miss this. So as you rightly said, sir, we need to be very, very mindful of anybody being lethargic and withdrawn, and consider hyperactive delirium in every admitted older person.
I can tell you that on the medicine ward, if the patient is very quiet, we are all happy. While if he pulls out tubes and brings the house down, then we take notice. And what Shahji said is very true, that we tend to ignore such people who's lying curled up on the bed and we think he's okay, while in fact he's not. That's true.
Sir, Tiju sir had also asked, but since geriatrics is facing most of the chronic conditions, they might have started the drugs for a long time. And is it easy to cut short the drugs so fast? That is again a question added.
Nobody says cut short the drugs immediately, but take each one at face value, assess it, is it really necessary? And that we do with rational prescribing, for which we conduct workshops all around. And whether that drug is really necessary, there might have. I mean, let me put it another way. We have many persons having either an H2 antagonist or a PPI as part of a package. Somebody puts him on clopidogrel and aspirin, and along with that adds a PPI. This is very, very common. Is it really necessary? And if the person cannot tolerate aspirin, there's no point giving it. It may be necessary under very special circumstances to give PPIs or H2 antagonists. But if under the circumstances of delirium, if H2 antagonists are contraindicated, we should take each one of the prescriptions, weigh the cost and its benefit and the advantages and disadvantages, and take a decision, take a call on it. That we should, the treating physician should have the guts to do it. What do you say? Yes, no other questions?
Any other questions?
Radharshan, did you have something to say? You plan to say something?
Not really. I mean, yeah, I agree with you. And we have the same situation in Australia. Like 30% of our medical patients have delirium. And as you both mentioned, the hyperactive delirium is more dangerous because it's underdiagnosed and undertreated. The other issue is delirium. If you look at 1 month mortality of delirium is higher than 1 month mortality of myocardial infarction. But it doesn't get the same mileage because it's a disease of older people, and you think they'll be confused. Most drugs have anticholinergic properties, so all drugs have side effects, and I think there are only very few drugs you cannot stop, like maybe steroids or insulin. Most of the other drugs you can stop, and you often patients do improve. So you need to do a cholinergic burden of any drug and then do it. The basic assumption is you need cholinergic transmission in the brain for neurotransmission. When you give an anticholinergic drug, there's no neurotransmission, and then people get confused. So it's very common. So 25% of our hospital admissions do have a drug-related side effect. It's very, very common. Going back to the other question about can you stop drugs in older people, what we don't realize, somebody would have been on the same drug for 20 years. And when people get older, your pharmacodynamics and pharmacokinetics do change. So they may need a lesser dose, or how they react to the drug at the receptor side is quite different. So you need to be careful with drugs.
I know a particular person whom Mohan will also know, and perhaps Radharshan certainly knows. One of our old professors was very attached to his wife. And when she died, what he did was to throw away a big bundle of medicines. And he said he never felt better in his life. Which means that many of the drugs we are giving, probably we should do a lot of introspection.
Can you hear me, Dr. Krishnan?
Yes, yeah. Hello. Raghu, come on. Welcome on board. Come on. Tell me, you had a question? I can't hear you. You're muted.
No.
Not unmuted.
It's unmuted, but please increase your voice. Please talk a little louder, sir.
Can you hear me now?
Very good.
Yes.
My question, it's not a question. I just want to add one of the points you said, especially patients with delirium. Many of them show abnormal restlessness and all that towards the evening after the sunset. So we call it as sundown.
Sundown.
So many times when residents go to the ward and see the patients, sometimes morning they'll see that the patient is quite normal. Then, but unfortunately, by evening, patient shows all the restlessness and other hallucinations and other symptoms. So this sundowning is a symptom of delirium and organic etiology. So that is one point we must keep in mind when observing patients. Just because during morning rounds the patient is quite normal, just cannot pass off the person as quite normal.
For most of us, the mornings are much brighter and better, isn't it? Anyway. There's a question from Tiju Thomas to everyone. Yes, of course, I agree with you, sir. But do you think a doctor will be having patience to see all the drugs and do the needful? I think geriatric specialty should come up to handle these type of issues. I think all of us have a responsibility to ourselves before we and to the patients, that we should ask ourselves whether many of these drugs are essential before you prescribe one. Second, when you see a patient with a long list of tablets, is it really necessary? Trim it down as best as possible. I think that's an obligation as a doctor to ourselves and to society. We must find them. And what steps we have to take to make available HR professionals to meet the demanding need of specialty? That's Subhadra's question. I don't know whether that's particularly answerable in this sort of thing. What does that do with delirium, Subhadra? I don't know. She's vanished. I can't see.
If you have a clinical pharmacist available in your hospital,
yes,
you can seek the help of them to sort out the polypharmacy issues and other things. And the drug-to-drug interactions, everything, they will look into it. And definitely that will be of use.
That's true. In our hospital, we have an excellent system by which if I've made an error in medication in terms of dose or frequency, they point it out, and we should take that advice on board and act accordingly. Of course, you're free to disagree, or you must establish that you need it with a certain reason. Of course, it's a discussion, and that is very, very important. Point well taken. Subhadra has vanished. I wonder where she's gone.
No, I am here only. I am here, sir.
What is this question you asked? What steps have we to take? I didn't understand. Not Subhadra's question, it says.
Yeah, it is.
Somebody else was proxying for you. Okay. Okay, shall we get on with it?
I think we can move on, or is there any more questions? Or else we'll move on.
Yeah, we can proceed, sir. Then the other questions can come later.
I need a little bit of help getting the screen back. Sorry. He's come. No. I want to go back. This discussion, but we go back to slides. So I have taken a few illustrative cases, and many of them are my own. I promise you that I have not used my imagination to make up any of these cases. I've divided, we said that the classification would be drug-induced delirium, neurological causes for delirium, non-neurological causes of delirium, and psychiatric causes. Let's take a few examples of neurological cases. The first step in a decision about whether this person who seems to be confused, withdrawn, or aggressive or whatever, is whether he does have a neurological deficit involving the dominant hemisphere or a non-dominant hemisphere lesion. All of those who are right-handed normally have our left hemisphere containing the speech center, and that is the dominant hemisphere. Very rarely does it happen otherwise. So if I'm a right-handed person, usually it's the left hemisphere that contains speech, and therefore it's called the dominant hemisphere, and the other is a non-dominant hemisphere. There are problems. Let's take an example of this 75-year-old lady who had a left hemiplegia, admitted to hospital. One of my brightest PGs presented this patient to me to say that she was not responding and was confused. But then I found that her eyelids were flickering. She was not unconscious, definitely. And so I walked up to her and said, if you can hear me, lift up your right hand. Your right hand. The left was a hemiplegic. And up it went. In fact, she was left-handed, and she had a left, I'm sorry, I made the mistake. She was a right hemisphere dominant, and she had a motor dysphasia. Sorry, I got it all mixed up. She had she had a dominant hemisphere lesion. She had motor dysphasia, and that was the reason why, with a left hemiplegia, she was unable to speak. I made the mistake. So a person with a left hemiplegia who was unable to speak she was unable to speak because the dominant hemisphere was involved. The other one was an uncle of mine who was living alone. I went to visit him. He got up from his sofa. He slumped, and he had a left hemiplegia. Well, what was wrong with you? Nothing. He denied all weakness. He seemed to be confused. What he had was anosognosia, which happens when you have a non-dominant hemisphere lesion where the person says that he has no illness at all. Denial of weakness. Oftentimes, to confuse the issue, hemiplegia is associated with hemianopia. So they can't see one half. So you stand next to the bed, and he doesn't seem to notice you at all while he speaks to somebody on the opposite side. And if on top he has an infection or some other problem, an arrhythmia or a myocardial infarction, he seems to appear confused. There was a 92-year-old lady who woke up at 3 o'clock in the morning, said she was very uncomfortable. And over a few minutes, she became drowsy and confused and developed a left hemiparesis. She had, in fact, a massive intracerebral bleed, went rapidly into coma. These are all examples of diseases which you cannot call delirium because there was a structural abnormality. A sudden onset of a seizure. I had a patient while I was working abroad who was an old doctor who suddenly came with a seizure. What he had was a herpes simplex encephalitis, and he deteriorated rapidly and went downhill, even in spite of using the antiviral drugs. Now, this is a clue. If you have a herpes simplex labialis, and for that you need a careful examination, this could be a clue that this person has a herpes simplex infection elsewhere. An MR, a CT scan, an EEG will help. An 84-year-old practicing doctor suddenly got into her car and asked the driver to take her to hospital. And she demanded that she be admitted. Everyone asked and said to her, why is this happening? She seemed very confused over the next few days. There were no lateralizing signs or signs of meningeal irritation. Imaging, etc. were normal. And she was labeled as being either demented or confused. And the LP was done. That was normal. The EEG was grossly abnormal, and she had, in fact, an encephalitis. So the first lesson to take home is that you should exclude a structural disease. Is it dysphasia, anosognosia, wherein a hemisphere is damaged? Is there a hemianopia? Is there an infarct, a bleed, or an intracranial space occupying lesion? And never forget subclinical seizures or encephalitis. None of these would qualify for the diagnosis of delirium. More interestingly are the non-neurological causes. An 82-year-old grandmother came who had been confused recently. She had a urinary tract infection and it became better with antibiotics. So the moral of the story is seek out an infection anyway. And it is important to take a proper history and a head-to-toe examination. Please send off cultures, urine, blood, whatever, before starting on antibiotics. You would have missed the bus. And as I mentioned earlier, if fever persists, consider drug fever. stop and proceed, as they say in the traffic department. An 85-year-old retired engineer had started disagreeing with his wife recently. To her, she was confused and had constant arguments. Why is he violently disagreeing with me? This is something new. And in fact, once we discovered that the sodium was low and corrected, he became perfectly all right. And his wife started predicting when his sodium would be low. Hyponatremia is a very, very common cause for delirium, and precipitating factors would include diuretics, a lesion, a chest infection, an intracranial lesion, or any other. So hyponatremia is important in the development of delirium. Something else also happens in a person who had acute gastroenteritis, who was admitted to hospital and started having behavioral abnormalities of one day. Sodium checked outside was 104. The hyponatremia was corrected in that hospital. And on the third day, she became aggressive and combative, and then became mute and had a slurred speech with extrapyramidal features. And the MR showed extensive lesions, not just in the pons, but elsewhere, all these. And what she had was extrapontine and extrapontine myelolysis, which we now know is part of the osmotic demyelination syndrome. A rapid correction of hyponatremia, and very rapidly too, and persisting for a longer period of time has a high morbidity. A total increase in serum sodium over 24 hours causes demyelination. It's not the hourly rate that matters. And if you stick to less than 5 milliequivalents increase per day, neurological complications are much less. So hyponatremia causes problems. Rapid correction to hyponatremia causes more problems. This was a professor who was 85 years old, was found confused and was noted to have a focal seizure. His blood sugar was pretty high, 500 mg/cent. We know that low blood sugars can cause seizures, but it's often not recognized that high blood sugars could do the same. And the history would tell us whether he had an incontinence, which he never had before at night, or a post-ictal headache or confusion, being important clues to his having had a seizure in the middle of the night or at some other time. This was a 70-year-old smoker who was diagnosed to have bronchogenic carcinoma. He was confused, he was constipated, and very dehydrated. That was a representative X-ray. You'll see the left upper lobe collapse there. He had clubbing. He had some, this I'm making up. He had some tenderness at the wrist, and there were changes which suggested hypertrophic pulmonary osteoarthropathy. So clubbing and delirium, you would think of a chest infection, lung abscess, bronchiectasis, not this X-ray. This is a left upper lobe collapse, malignancy, chronic liver disease, and infective endocarditis come in the differential diagnosis of clubbing. And you should be looking for cervical or axillary nodes very, very carefully. And this man who had bronchogenic carcinoma was confused and constipated and dehydrated, had hypercalcemia. This is the triad of confusion, constipation, and dehydration, which should alert you to hypercalcemia. And when you're checking the calcium, please check it fasting and without a tourniquet. Long list of causes for hypercalcemia. We will not go into that. But the commonest causes are osteolytic bone metastasis, myeloma, and hyperparathyroidism. So it's not just the sodium, sugars, calcium, and even ammonia, a flap, splenomegaly, and would indicate chronic liver disease. This is the story of an 82-year-old who became mildly confused and disoriented. There was another one, I remember, of another 90-year-old lady who was living alone. There was an unexplained tachycardia and postural drop in blood pressure. And both of them had GI bleeds, and both were documented by upper GI endoscopy. So a GI bleed, a gastrointestinal bleed, a peptic ulcer that bleeds can cause a person to become mildly confused and disoriented. If the same combination of unexplained tachycardia and postural drop in BP were associated with fever, straight away you would consider gram-negative sepsis and try to exclude urinary tract infection and a chest infection. This is the story of a 70-year-old lady who had chickenpox. She was normally perfectly well, but on that day, she was totally confused and agitated and aggressive. We wondered whether it was a stroke or encephalitis or an infection or the usual things. But she realized that she had fecal impaction, and on her own, she disimpacted herself. This is very strange that a non-medical person should do this. And it is important to emphasize that a rectal examination is a must for old people, and it's part of your examination. And if you find that the rectum is empty, please ask for an X-ray abdomen to see if it's a high impaction. The other thing that will happen is the relatives and the patient will tell you, oh no, I moved my bowels. And if you ask, they'll say that there was some liquid stools, and it's usually a scabious mass in the rectum or higher, around which fluid feces flows out. So rectal examination is part. If the only thing that I can pass a message is that the importance of a rectal examination as far as these cases are concerned. So in addition to bleed, impaction is a serious cause, a serious GI cause for delirium. This is the story of a 75-year-old lady who lived with her son, and she had been on dabigatran for atrial fibrillation. Cataract surgery was recommended. The dabigatran was stopped, and 3 days later, the brother was sleeping in the room. She woke up her brother and said, "Look, I see people in the room. What are you? Why are you letting them in?" And she was hearing things, seeing things. And the question is whether a psychiatrist should be involved. A very subtle right faciobrachial weakness was picked up. Palmomental, very small change in the reflexes on the two sides. Because I had seen the patient earlier, it stood out. And very, very tiny subtle changes in neurology should alert the physician that there is a structural change. She got better on her own. They did see a psychiatrist who gave her some quetiapine and enema for fecal overload. There were other causes too, but she got better. She had the cataract surgery and she went home very well. So multiple causes, and signs may be very subtle. This 85-year-old retired teacher had a sudden onset of altered behavior for 4 days. Her sodium was low. That was all that we got from the ED. And on a careful history, it turned out that 4 days prior, she had started having abdominal symptoms with 2 episodes of fever, rigors, and chills. And then the altered behavior began. So obviously, it was a GI cause for sepsis. And on examination, the slight abdominal distension and right paramedian scar were picked up. And she had a globular right lower quadrant mass, which we initially thought could be a volvulus or an appendicitis. The GI surgeon here also saw. But then the abdominal CT revealed nothing terrible. And she did have fecal impaction. She got better. There was a GI cause. Maybe it was a diverticulitis or something very tiny, but there was nothing to show for it. And incidentally, I must say that piperacillin tazobactam under these circumstances is a wonderful drug, because what we all do not recognize is that there's a lot of sodium in the vial, which is, if you look carefully, you'll find in the product insert that there's a lot of sodium. So in a person with hyponatremia, if there are no other contraindications, piperacillin tazobactam is a good choice. She generally got better and went home. But went out of the ICU. But then she had a slurred speech one day. Relatives felt an MR scan would be indicated. We did it primarily to exclude a subdural hematoma. There was nothing there. And then in the ward, she collapsed again. Aspiration was excluded. There was no specific neurodeficit. GCS was pretty good. It was 14 out of 15, but she had subclinical seizures. And then again, because she did not improve, she was started on anti-epileptic drugs. She did not improve again. And so she had some extrapyramidal manifestations, and the MRI, when repeated, showed that she had fresh emboli all over. So multiple causes, neurological disease could make delirium. In fact, she had come out of delirium, but then it went back to a sad state, unfortunately. As the illness evolves, you should be looking for new causes. Now, this is an 84-year-old gentleman who caused a lot of alarm, because lots of people were asking why was he getting better. And then a few days later, he broke out into this rash. And we must realize that any infection could cause delirium. In this patient, it was dengue. We have all heard during our college days of typhoid delirium. And we should remember that high fever with bradycardia disproportionate to his fever. It may still be 90 or 100, but when he has a fever of 103 or 104 degrees, that heart rate is disproportionately low. And if you look carefully, you might find a splenomegaly, and that's, you're dealing with typhoid delirium. Fever plus a vertebral tenderness, we have picked up osteomyelitis that way. Fever plus intercostal tenderness, we have picked up liver abscess. And I must say that some of my old professors did all this on clinical grounds, and I must acknowledge their influence on me. So any infection can precipitate delirium. As Alex said, alcohol excess, maybe associated hypoglycemia, can cause trouble. More so alcohol withdrawal, which we may not recognize. The person has come into hospital for something else, maybe an RTA or something unrelated. And then 3 or 4 days later, he starts behaving funnily. And we should remember to ask about delirium tremens, complicating the person's illness. There is this, I must, there was, oftentimes we give alprazolam, and 4 or 5 days later, they have withdrawal symptoms if we stop it. And this is very, very common. And last but not least, we should talk about an 82-year-old lady who had multiple comorbidities. But going by the history, she had been occasionally confused for the last 1 or 2 years. She wandered around, left doors open. He lost her way home twice at least. She was shabby. She soiled herself, was unsafe in the kitchen, leaving the gas stove open, and sometimes would ask where she was. But please remember that it is any infection, biochemical imbalance, or fecal impaction can make her mental status worse suddenly. Dementia is a slow progression and will not cause a sudden change in mentation. Clinical assessment has to be done meticulously, a proper history, make it focused, look for skin lesions, search out little nodes. As we said, alcohol or sedative drug withdrawal, autonomic nervous system activation may be blunted or absent in an older person. It may not be very obvious. Anticholinergic toxicity may occur after eye drops that the ophthalmologist prescribes, or even beta blockers applied locally to the eye. As you go near a patient, there is this distinctive smell of urine or of melena, which you should not miss. Alcohol, the smell of alcohol, the smell of kerosene in poisoning especially, the smell of anaerobic infection, as happens in bronchiectasis, feta hepaticus, ketonuria, could all be distinctive as far as smell is concerned. Do not forget to look for a bitten tongue or a fracture dislocation. In seizures, signs of head injury which may be missed otherwise, the battle sign. Raccoon eyes are pretty common and very distinctive, you can't miss it. And subhyaloid hemorrhages would be a feature of intracranial hemorrhage and missed if you did not look into the fundus of the eye. Nuchal rigidity may not always signify meningitis in an older person. A metabolic flap is very, very common, and it can happen in a variety of causes of delirium, whether it is liver failure, renal failure, or any other. And as I said earlier, look for little nodes, and in all the unusual places, the axilla or the abdomen, to look for tuberculosis or malignancy. And it is important to remember that fever may not be manifest in the context of infection, and rebound tenderness and other signs which you normally expect in a young individual may not be present in the old. It may be prudent to photograph skin lesions, especially for follow-up, but do so only after permission these days. This is a person who had the characteristic changes, the infarcts and hemorrhages of infective endocarditis, and we went on to publish it. The Janeway lesions, which are very, very rare, the Osler's nodes, and the signs of meningococcal meningitis. If you don't look for it after removing the clothes, you may miss it. The dry skin of hypothyroidism, acanthosis nigricans, which you can see in the axilla and in the neck, and a diffuse rash and the eschar, which all came up only because the clothes were removed. And this is a patient of mine who had abdominal pain, very, very severe. And there was no cause, no skin lesions at that time. But just before the surgeon laid his knife on her, he discovered these small vesicles of herpes zoster. Signs of infection in the young may not be remarkable or correct or dramatic. And in a neurological examination, what's the most worrying thing is that you may find that there are very non-specific changes like multifocal myoclonus or asterisk, which does not lead you to a focal neurological deficit. But in that context, neuroimaging or EEG would certainly help. A lumbar puncture would also be necessary. Wernicke's encephalopathy is often is sometimes missed. The triad is mental confusion, ophthalmoplegia, and gait ataxia. Don't wait for an MR. Get on with giving thiamine 200 to 500 milligrams. Korsakoff syndrome, a longer duration, a chronic amnestic syndrome, but that could be the reason for the person's confused behavior. I will stop here in the sense that I will not go on about the list of investigations. What is appropriate, you must do. But the most important science, exciting phrase to hear is, and when you make a discovery, especially clinically, is, well, this is not right. This is funny. And that's what Isaac Asimov said. Management-wise, the aim of medicine is to cure occasionally, relieve often, comfort always, to which Papworth added, but never harm. This is Claude Bernard with his students. And in the ICU or in the ward, beware of restraints and cot sites. Use the minimum drugs or interventions. In the lowest dose, beware of torsade de points or postural hypotension. And perhaps first generation antipsychotics like haloperidol are okay, and even the second generation, they're comparatively safe, but where you can avoid drugs, that would be best. So preliminary assessment, is it sudden, is it old? A long list of drugs which you would like to avoid, Is there sepsis or any underlying cause? A neurological damage excludes delirium. A quick checklist which we have gone in great detail, and the less common causes of hypoxia, hypercarbia, and so on. And again, a history, a proper physical examination, followed by what Sir William Osler said, contemplation. Are you doing the right thing? Have you got your diagnosis right? Is the most important. The only thing I wish to emphasize on this slide is fecal impaction is under-recognized in this country. There may be multiple causes in the same patient, and always be considerate to the patient and relatives, and be judicious with the use of technology. Just because you have it, it does not mean that you have to use it. For a person with a hammer, everything looks like a nail. Please don't rush to the psychiatrist and say, please solve the psychiatric problem for me, for it may not be. And you look very foolish when he turns around and tells you that this is delirium after all, and it's your job to sort it out. All drugs are best avoided, and try not to use tests indiscriminately. But where cure is possible, go hammer and tongs for it. And last but not least, Lord, give me the serenity to accept the things that I cannot change, the courage to change what I can, and the wisdom to know the difference. Thank you for your attention. Hello, I'm done.
Thank you, sir, for the wonderful presentation. ആർക്കെങ്കിലും സംശയങ്ങളുണ്ടെങ്കിൽ ഇപ്പോൾ ചോദിക്കാം. ആദ്യം ഞാൻ പറഞ്ഞ കാര്യങ്ങളിൽ ഇപ്പൊ അതിശയോക്തി ഇല്ലെന്ന് എല്ലാവർക്കും മനസ്സിലായിട്ടുണ്ട്.
Hi, I'm Dr. Rajmohan. Krishnan, can you recognize me? I'm Dr. Rajmohan. I'm basically a pediatrician, but a public health man now.
You have changed a lot anyway.
Okay. See, my question to everybody, especially it was a very, very enjoyable clinical elucidation. But my question is, as a socially committed clinician, have you ever thought of this question? That is, the services for the elderly has two dimensions. One is the societal response to the needs of the elderly. That is the civil society's responsibilities, and how do they perform it? And second one is addressing the medical needs. That is, of course, the profession has to look after that. These two things are separate entities. Now, there is a policy for the elderly. Now, see, the elderly is increasing. We had a decade of elderly, all those things. It is a reality. And now it all matters how you transform the system to address these two types of needs. On the one side, to the medical needs of the elderly, and the other one is the so-called social needs of the elderly. So my question is, as a clinician, who is socially committed, how do you feel it is going in harmony, both these things? For example, the social needs of the elderly or the civil society responses, like the health system transformation towards the addressing the needs of the elderly, whereas the non-health system aspect transforming the needs. For example, if you look into I don't know, there are a lot of noises. If you look, see, the problems are very simple. There are degenerative problems. You cannot treat it. You can only mitigate it. You have to go with it. Then there are problems of elderly fall and things, which are again, it is a matter of environment. There are multiple factors contributing to it. It is environment has to be made elderly free, transport has to be made elderly free. There are a lot of policy changes which we need in our society to prevent these things.
You mean elderly friendly, not elderly free. You meant elderly friendly.
Elderly friendly. I'm saying elderly friendly. It's a matter of quality of adjusting with the quality of life. So what I mean is, it is all a matter of transforming our systems, both health systems as well as non-health systems, towards a quality of life, which is a prudent elderly life here in the elderly period. And because the elderly is coming up and their problems are coming more and more into visibility. So my question is, as a committed clinician, how is your observation about this harmonious going? How these things are, the transformation of our health system as well as the non-health system, civil society responsibilities. There are elderly policies. A lot of things are there. Social security measures for elderly. Everything is connected.
I understand your enthusiasm, but the problem is that there are certain things we can do and certain things we cannot do. I've seen geriatric practice in hospital, in a very good hospital, a teaching hospital where I worked, as against how they do it in the community. Now, as clinicians, our job is to provide care to people who come to hospital. Maybe even at home we can go and do it. But when you ask about civil society, there has to be an intrinsic change in thinking, which you and I can influence, but have no control over. That is, but you will realize that as in everything in India, lots of things have changed for the better. I mean, whether it's a post office or the courier system or the transport or the train or the plane, everything has changed. And we hope it may not be in our lifetime, but it will change for the better, I hope. But you must also realize that what happens in the West is not completely right. I have seen, surprisingly, scurvy in the West. And that was because this old man was living alone and was subsisting on toast and tea, which was being given by the health nurse or some neighbor or something like that. And he had no access to vitamin C. And this is the only classic case of vitamin C deficiency I have ever seen. So don't say that everything in the West is good. We have our advantages. We live in a society where somebody else, your neighbor pops in and looks after your needs. Maybe go to the bank, get some money, get some food, and maybe even feed you or clean you or wash you up. We are going the Western way, but all that is in the West is not perfectly right. I think there has to be a balance. And in response to your question, what about civil society? The point is that civil society should see that it is not directed entirely West. We have our own system of a Kutu Kudumbam, which had its advantages. Now it's all gone. It's disintegrated. It's unitary families. So I don't think there's a short answer to your question, but we all have to contribute to change. I'm sure Kishan Nair, who has seen the East and the West, might be able to take it a bit further. What do you say?
No, I agree with you. Yeah, we have our problems too. Yeah. Thank
you. Thank you very much. Thank you.
I hope I have answered the question, but this is a very philosophical question. Nobody can answer.
I think Dr.
No, it is not a philosophical.
Dr. Shaji, who has been working in this area
Shaji,
for a long time.
Shaji, you may have a lot of treasure of knowledge about our own system. What do you feel? What do you feel? Because this is a real genuine demand.
There is this very important statement which can be made. That is, medicine has to change itself to look after increasing number of older people. We look after children differently. We understand their needs. We look after special needs of women, disabled, but then we do not take care to understand and meet the needs of older people. I think medicine has to change the way it treats. And as you rightly said, without social care, then there cannot be good care. So this has to go hand in hand. I agree with you, sir.
Thank you very much. Thank you.
Can I make one statement also? That is, I think 10% of all older people who get admitted to medicine wards will be admitted when they have delirium. Another 10 or 15% will have delirium, which is incident during their inpatient treatment. This, now we know that this can be prevented by certain interventions like prevention of dehydration or ensuring that there is good hydration, that we take care of fever, we look after their sensory problems, like you ask them to put on the glasses, hearing aids, and ensure that there is early mobilization and they do not get exposed to drugs which worsen cognition. If you can do this much, you can actually prevent the incidence of delirium in hospitalized medical patients. I think this we will have to, I'm sure university or some of us can make it a policy that all inpatients who are being looked after in hospitals, tertiary care settings, there must be a policy that there will be efforts which will be made to prevent incident delirium, because delirium predicts poor prognosis in older people. Thank you for again emphasizing that it is multifactorial in older people than being due to one cause.
I must add,
always multifactorial.
Shaji, I must add one little point. I must congratulate the university for taking the initiative for this. And if it can disseminate information about care of the old among our own doctors, let's set our house in order first. And that is the first step in achieving a global perception of the need for care. And I have a vested interest. All of us are getting old, and therefore I would need some smart people to look after me. There's a question to Kichu Nair who's come from Tiju Thomas. Question, I don't know, can you see it on your screen, Kichu?
Yeah. He's asking what's the difference in geriatric care in Australia and India. I think the main difference is we have more people training in geriatrics, more people trained in geriatrics. All hospitals have geriatric units. There's no more money spent in research. And there are a lot of community services where we can get nurses and other people to go and look after older people. So it's more structured, but we still have a long way to go. So we still have 15% of older, 15% of the population are above the age of 65. So proportionately, we have more older people, but in absolute numbers, India has more older people because you have a bigger population. We have more resources though. Thank you.
Thank you, sir.
As Dr. Krishnan has said, all of us have got the vested interest that the geriatric care should improve. I also joined the same bandwagon. In fact, not only the medical care, the another very important area is the nursing care, nursing service. In fact, some time back, my classmate who is in Japan, he said, can you provide geriatric nurses? Then Japan is a great opportunity. Can you send us? We can take thousands of nurses. And somehow they think that Indians will be better, so that they would like to have Indian nurses. So these are all the areas, of course, rather than exporting them to Japan, I think we can train them for India also. So geriatric care is a great area. And in fact, many of us will be feeling that very sick old person at home, and the youngsters or middle-aged people, they're all going for work and nobody to take care of them. And there is no system in the country, and you don't have trained people also. So that's a big area. I think we will have to, university will have to look into that. We'll have to try whether we can arrange some training modules for that, so that we can train people in that area also.
One more thing, Mohan, which I must say, that even shortly after the Second World War, when geriatrics became a specialty in Britain, for several decades, it was a Cinderella specialty. The brightest and the best would not take up geriatrics. They all went into cardiology, neurology, and so on. Over the years, perception has changed. And now everyone knows a lot of geriatrics because it's part of undergraduate curriculum. And there are enough opportunities for committed young people to do quality work in geriatrics. Unless that change is brought about in India, in fact, it's a very fledgling specialty here. Nobody knows anything about it. And if you ask a young person who's just finished his MBBS or MD, what do you know about geriatrics? The answer is zero. That only people like you in the university and the Medical Council of India can change. If it becomes more attractive to take up jobs in geriatrics, more and more young people will take up the specialty. I've seen this happen in my time about very, very bright people taking. I know a neurologist who changed tack, Ray Tallis, if I may mention the name, a brilliant neurologist. He changed tack and became a professor of geriatrics and did absolutely remarkable work. Incidentally, Raghuram and others will know he writes poetry also. So there was a kindred spirit. So therefore, I know him reasonably well. So there has to be a direction from the government, from society, as Raghuram pointed out, that that is an attractive specialty. There's a lot of challenge in it. And there's a lot of satisfaction. You don't know the amount of satisfaction you get when you see an old person getting better and thanking you. And he is very sincere about it.
I think there's a lot of studies in the United States where people looked at the job satisfaction, and geriatricians and internists had more job satisfaction than, say, ENT surgeon or orthopedic surgeon. But the other issue even facing Australia is the colleges or the government will have to regulate the number of specialists we train every year. That should be proportionate to the need of the society. That doesn't happen still even in Australia, because most people will choose a specialty where they can make money. So they go to procedural specialty. But fortunately, as you mentioned, some of the younger trainees are choosing geriatrics as a specialty or internal medicine, but they see job satisfaction and career opportunities. Yeah. So we have to work together. I think society will have to work together with the medical profession to train people for the needs of the society. If you have 100 million people in India above the age of 65, you need more people to be trained in geriatrics. And that doesn't happen. In fact, a Lancet editorial recently said, the common condition we all treat in 2020 is multimorbidity. It's not ischemic heart disease or stroke. It's a multimorbidity we all treat every day. So unless we train people to look after the multimorbid, frail, older people, we are not doing the service to the society or justice to medicine. Thank you. I really enjoyed your talk. Thank you.
Thank you.
There is one more question from Dr. K.N. Pai. In the coming time where we have to live with the COVID, where elderly are cocooned or bubbled, do you feel more mental health issues are coming up?
I think Shaji would be better at it than me. But sure, yes, we all live in difficult times these days. The old are not exempt from any of these problems. Probably they are more isolated and feel more estranged from society. What do you think, Shaji?
I think this is a huge issue. I think the care of older people are going to shift to homes, their own living spaces. And then the largest number of deaths are reported from care homes elsewhere. So there's a growing concern now. There is a crisis in Kerala that you cannot get admitted to an old age home now. You cannot visit your relative who is in an old age home now. And old people who are in old age homes are being isolated and kept under social deprivation, which, if it lasts for a long time, will have very serious adverse consequences on their mental health. Actually, we are discussing these topics in great detail in the next 2 weeks. As Dr. Krishnan said, these people have multimorbidity. People, whether they are at home or in the care homes, they have multimorbidity, and the care of chronic diseases had got very, very low priority or no priority in the last 3 months in India. So this, we are going to face acute emergencies on chronically ill, comorbid, multimorbid people in the next 3 months. I'm really scared that we are going to face a crisis in geriatric care in the next 3 months.
I think to take it further, we have done a lot in the sense that we have provided Kerala models for everything. Why don't you and Mohan and everybody sit together and have a Kerala model for geriatric care? It could be something.
I think we are discussing this, sir, and I think
Yeah.
this is a forum which we should take that discussion. I would request the VC to take this forward. I am willing to volunteer time for. I'm sure Kitchen Dr Krishnan and everybody else. I think we need to plan for what is the likely future for geriatric care to begin with in southern India and rest of India.
I don't think we should ape the West at all. We have our own robust systems which we should utilize.
I fully agree with you, sir.
Definitely, the university will take it. Definitely. Regarding the old age home, now the government has come out with a plan to test all the inmates in old age homes about COVID. Now, that's a big initiative they have done. And let us see what is happening. If all the old age homes are free from COVID, and then maybe some strategic move so that they can be exposed to people who are COVID free or who had COVID and now they have been treated as negative. So such people can go there. These kind of things can be worked out. And Russia has just tested the first COVID vaccine. Somebody said that Putin has tested on his own child. So let us hope that comes. So then the first priority will be our elderly people. So let us hope. Because hope is the best thing we can have in this bad time.
I think all good things must end, Subhadra. And I think
There was one
Yeah.
Suma madam raising her hand. There was one Suma madam raising her hand.
Yeah, Suma, please.
I was thinking that it has been decades. We started talking about geriatrics as a separate specialty. But when you are looking at what is happening, not much is happening. I think in Trivandrum, there is a geriatric department, some activities are happening. All the other places, it is only for namesake. So there are not much of people who are trained in geriatric care or how to look after all those things are not there. And as has been just said, I think this is a good chance for the university to take up, at least for the training of the professionals and also the doctors and the nurses and even others on geriatric care. And if you start it from one end, I think there'll be at least some people will be interested and will be focusing on the geriatric care. Because I remember that about 20 years ago that there was a circular saying that every medical college will have a geriatric department. But I don't know how many of the departments are having a geriatric department.
Suma, if you there's a problem with starting a geriatric department on its own, because when I came back from England, it was suggested that I should take it.
Alfonso, please mute. Alfonso, please mute. Your child's voice is coming out.
What happens is that if you have a department of geriatrics, as happened perhaps in Calicut Medical College or wherever, you have 4 beds, and everybody from the orthopedics or general medicine would send patients to you, and you have, unless the society is geared to taking them back, unless physical medicine and rehabilitation is so competent as to get them back on the feet, that is not a good option. I feel it should be integrated into general medicine. And it should be a common pool for it's everybody's problem. It's not the geriatricians alone problem. It's the general medicine, cardiology, nephrology. Everybody should be involved. Anyway, that's not subject of this discussion.
Thinking about that geriatric department like that, but it should be a combination of all.
It should be a combination, because if you have just a few beds for orthopedics or nephrology, that like that geriatrics, it will not solve any problem. I'll talk to you in person about it.
Yeah, there should be a training going on. People should know what to do.
Training, information, dissemination of knowledge are all part of what the university has set this up, and I think that needs congratulations and kudos.
University definitely will have certificate courses on gerontology, and as Professor Krishnan has rightly said, rather than making a department and shunting all the old people to that department, every specialist should know how to treat an old person.
Exactly.
How to treat an old person with an ophthalmic problem, an old person with an ENT problem, a medical problem. Probably except pediatricians, everybody should know how to treat an old person.
And radiologists.
Yeah, radiologists will have to see everybody. So
you don't have to treat them.
We generally, now we are treating interventional radiology and we do it more on older people. Thank you, sir. Yeah.
Thank you very much.
Thank you for the excellent presentation, Krishnan.
Thank you. Where's Subhadra? She's vanished.
Yeah. Here only. I am waiting for anybody to raise questions. So I think it is time to wind up.
Thank you very much. Thank you for giving me the opportunity first, and for being able to speak to all of you and interact. It's been very informative. Thank you.
Thank you. Thank you all. Thank you. Thank you so much. Thank you.
Thank you.
So ഇത്രയും ഒരു ഫലപ്രദമായ ക്ലാസ് നടത്തിയ സാറിനും സാറിന്റെ BMH ടീമിനും അവർക്കും പറയാതിരിക്കാൻ കഴിയില്ല. അവരുടെ സഹായം നല്ലോണം അവിടെ നമുക്ക് കാണാനുണ്ട്. ആ ടീമിനും ഞങ്ങളുടെ നന്ദി അറിയിക്കുകയാണ്. കൂടാതെ ഈ പ്രോഗ്രാം സാധ്യമാക്കിയ VC സാറിന്റെ ഒരു സപ്പോർട്ട് ഇല്ലായിരുന്നെങ്കിൽ ഇത് നടക്കില്ലായിരുന്നു. VC സാറിനും PVC സാറിനും രജിസ്ട്രാർ സാറിന്, ഡീൻസ് ഓഫീസ് സ്റ്റാഫ് ആൻഡ് ഗീത മാഡം ആൻഡ് ടീം ആൻഡ് ഓൾസോ സിസ്റ്റം മാനേജർ ആൻഡ് ഹിസ് ടീം. ഞങ്ങൾ എല്ലാവർക്കും അറിയാം, എല്ലാവരും ഏത് സമയത്തും അവരെ വിളിച്ച് ശല്യം ചെയ്തുകൊണ്ടേ ഇരിക്കുന്നുണ്ട്. നെറ്റ് കിട്ടിയില്ല, പിന്നെ പാസ്വേഡ് ശരിയായില്ല, ഞങ്ങളും കുറെ പ്രാവശ്യം ചീത്ത പറഞ്ഞു വരെ. അവർക്കും എല്ലാവർക്കും ഈ സപ്പോർട്ടിന് നന്ദി പറയുന്നു. സാറിനുള്ള നന്ദി കൃഷ്ണ സാറിനോട് എത്ര പറഞ്ഞാലും മതിയാവില്ല. സാറ് കുറെ അധികം പണി പിന്നെ യൂണിവേഴ്സിറ്റിക്കും VC സാറിനും കൂടെ തന്നിട്ടുമുണ്ട്. അതുകൊണ്ട് സാറിന് VC സാറിന്റെ പിന്നിലും ഞങ്ങളും എല്ലാവരും സപ്പോർട്ടായിട്ട് ഉണ്ടാകും എന്ന് പറഞ്ഞുകൊണ്ട് സാറിന് നന്ദി അറിയിക്കുകയാണ്. എല്ലാവർക്കും നന്ദി അറിയിച്ചുകൊണ്ട് ഇതിൽ പങ്കെടുത്ത എല്ലാവർക്കും തന്നെ, പ്രത്യേകിച്ച് സുമ മാഡം, കിച്ചു സർ, ഷാജി സർ, എല്ലാവർക്കും ഞാൻ നന്ദി അറിയിക്കുകയാണ്. പ്രോഗ്രാമിൽ വന്ന ഓരോരുത്തർക്കും ഞാൻ നന്ദി അറിയിച്ചുകൊണ്ട് ഈ പ്രോഗ്രാം ഇവിടെ സമാപിച്ചതായിട്ട് പ്രഖ്യാപിച്ചുകൊണ്ട് നന്ദി, നമസ്കാരം.
Thank you.
Thank you.